Like last month, we have a very successful journal club by the line and very interesting discussion. And my understanding is the commentary already go to the cardiovascular pathology journal. So it's very good. To continue the success last month, we will have another very good speaker, Melanie Boyce, a rising star in cardiovascular pathology. She is associate professor at Mayo Clinic with over 70 publications in peer-reviewed paper, books, and editorial. Other than clinical service, she is a very good teacher and elected Teacher of the Year for Mayo Clinic and anatomical pathology. At national level, she is associated editor for the social medium of Cardiovascular Pathology Editorial Board, and also the chairman of membership committee of Society of Cardiovascular Pathology. Without further ado, Melanie.
Oh, thank you so much. That was a very kind introduction. And I'm really hoping to bring this journal club to all of you because I want to hear your commentary and I want to hear your thoughts. This is obviously, it was with some trepidation that I chose these two articles. I know this has been a hot button for all of us. We've been really interested in this from a research perspective. And for that reason, I wanted to bring you two articles that we could discuss and have a informative conversation about. So with that, we'll get started. Let's see if I can make the slides advance. That will be step one. All right, there we go. So I chose two articles, one coming out of Madrid, Spain, and one coming from the state of New York here in the States. And before I delve into these in a little bit more detail, I wanted to provide a bit of background about the history of myocarditis and exactly how we're ending up in this conversation and why I found these two articles very relevant. So this is a very high level, very brief overview, but essentially in 1987, the Dallas criteria were established, and they were established based on a consensus conference that occurred the year prior in Texas by 8 cardiovascular pathologists. Out of this consensus conference came 2 publications, one on the histopathologic definition and classification of myocarditis, and one appropriately entitled the Dallas criteria. This first article I found very challenging to get a hold of. If anyone wants a copy of the original, I do have it. I'd be happy to provide it to you, but it's a fascinating read. Essentially, this established a baseline for the histologic diagnosis of both active myocarditis and something called borderline myocarditis, wherein there was no myocyte injury. We used this criteria for a very long time, but it wasn't without its faults. And I think we started to recognize that kind of right out the bat, there were certainly some publications coming out about, what could be improved on the Dallas criteria. And then around the turn of the century, we began noticing more and more, and there was a stronger call to revise this criteria. Essentially, these criticisms sort of cited variation in expert interpretation or inter-observer variability that occurred on these endomyocardial biopsies, something that we're seeing today, maybe even more so than we did back then. Variation in treatment outcome, whether or not there was actually inflammatory component to these endomyocardial biopsies and how that actually predicted clinical course. Sampling error and lack of sensitivity was also an issue. So there was a call in the early 2000s for a more integrated diagnosis with clinical parameters, and then also trying to increase that endomyocardial biopsy yield with the use of immunohistochemistry and polymerase chain reaction for viral nucleic acid. The European Society of Cardiology answered that call in 2013 and provided a working group consensus document on myocardial and pericardial diseases, essentially recommending that tissue from endomyocardial biopsy have histology, immunohistochemistry, and viral PCR performed on the heart, and the viral PCR also occurring on blood samples. So from this point, from about 2013 on, we started to notice a more divergent practice. There were local regional variations in the way that we diagnosed myocarditis, and I think Largely, this is an editorial on my part, but I think largely our own institutions and our own clinicians got very used to our interpretations and how we did things. And I think we've started to really drift apart when it comes to the diagnosis of myocarditis and how we all interpret a similar histologic slide. Nothing probably brought this to the forefront more than the emergence of SARS-CoV-2 in late 2019. I think we all started to focus on this issue a bit more and recognize even more shortcomings than what we had listed previously. Specifically, this criteria mostly applied to endomyocardial biopsies and wasn't very applicable to autopsy or explant specimens. And there was less of a focus on the histiocytic inflammation than maybe we should have been having. So we started to notice that there was histiocytic interstitial inflammation that can be associated with myocyte damage. And that particularly became apparent as the COVID-19 pandemic continued. So it's with that background that I want to introduce you to the first of the two articles today. The first one is endomyocardial biopsy confirmed myocarditis and inflammatory cardiomyopathy, a clinical profile and prognosis. And as I mentioned, this is from a group out of Madrid, Spain. And they did a very nice job correlating the endomyocardial biopsy, histologic findings, immunohistochemical findings, and clinical outcome, and really trying to ferret out which of those are most important in making this diagnosis of myocarditis. So as they introduced their article, essentially they rested on a lot of the issues that we talked about. The yield of the Dallas criteria is relatively low. The sensitivity is somewhat poor, but still we really rely on histologic diagnosis as that gold standard for myocarditis. So can we use immunohistochemistry to improve that yield, to increase the sensitivity? And this question isn't novel. It's something that has been explored in the past, but this publication came out at a prime time in 2022 when we are all in the process of trying to understand this concept a bit more. So I think it's very informative to discuss, and I want to thank Dr. Holushka for bringing it to my attention. So they included patients with a suspected diagnosis of myocarditis or an inflammatory cardiomyopathy over just over a 20-year period, so 1997 to 2019. And all patients who were included underwent endomyocardial biopsy based on inclusion criteria from the American Heart Association criteria. I have those listed. I won't go over them. If you're interested, we can certainly discuss that. This was a single institution, a tertiary care institution, and has some bias built into it from that, which the authors readily acknowledge. With regard to the clinical, they did look over EKG findings, echocardiography, and cardiac MRI where available. The cardiac MRI was graded based on the classic 2009 Lake Louise criteria for myocarditis, so not the more updated 2018 version. There were salient clinical parameters that were extracted, including a history of arrhythmias or ICD placement. And then from the pathology side of things, they looked at endomyocardial biopsies and graded them for a diagnosis of active myocarditis by the Dallas criteria, and then stained all of them with CD3 to evaluate for immunohistochemical criteria. All of these were done by a single pathologist. It doesn't really list whether there was a washout period or whether the cases were blinded, but we assume that they most likely were. All right, so with regard to the table, this is table 1 from the study itself. Listed on the left is your baseline clinical parameters, and then the total in each category for the entire cohort. And then the columns to the right are subdivided into those that had a histologically confirmed diagnosis of inflammation or myocarditis. And this was either by just light microscopy or immunohistochemistry. So a total of 57 out of 99 were positive for myocarditis. And then this column here lists those that were not confirmed, so no inflammation in the heart or no myocarditis. And then the p-value relevant to those two subgroups are listed on the right-hand most side of your slide. The indications for endomyocardial biopsies are relevant to this discussion. So acute myocarditis with hemodynamic instability was suspected in about a third of the cohort, whereas a more subacute or chronic kind of dilated cardiomyopathy picture was in 2/3 of the cohort. Now this slide was not in the original paper, so I took the liberty of adding it mostly so I could understand a little bit better what we were seeing and what the increased sensitivity was with immunohistochemistry. So I hope you'll allow this editorial into this discussion. But essentially, there were 99 patients that underwent endomyocardial biopsy during that slightly over 20-year period. So 99 patients over that timeline. 33 of those were suspected acute myocarditis, 66 suspected for that more subacute or chronic picture of a dilated cardiomyopathy or inflammatory heart disease. And then those that just based on histology, so just based on that 1987 Dallas criteria, 42% of the acute myocarditis were positive by Dallas criteria. And of the inflammatory heart disease picture, we only had 23% that were positive just based on histologic criteria of the Dallas criteria. If we then take into account the immunohistochemistry, so this is adding in Dallas criteria plus immunohistochemistry, you can see that the overall numbers do increase in both categories. And I've listed the p-values here. So essentially taking within that inflammatory heart disease category, the numbers increase, the number positive increased from 15 just by light microscopy up to 34 by immunohistochemistry, which was a significant increase that we saw by the use of immunohistochemistry. The numbers were a little bit more modest when it came to acute myocarditis, but still an increase from 14 to 19 patients with a significant p-value. So still seeing an increase in sensitivity when immunohistochemistry is applied to endomyocardial biopsy. If you then talk about the types of myocarditis that were diagnosed, overall there was 57 cases that were diagnosed. The lion's share of those were lymphocytic myocarditis, and then a very much smaller subset for eosinophilic sarcoidosis, and then one case of giant cell myocarditis. And then this listing these gray and green pieces of the pie here, basically listing either those that were no significant histopathologic abnormalities or some fibrosis that was present without either immunohistochemical or light microscopy findings of myocarditis. Again, this is a Melanie-ism that is editorialized into this presentation, but essentially taking a look at how these different types of myocarditis were diagnosed, either being by the Dallas criteria, immunohistochemistry, or the diagnosis, the methodology of the diagnosis wasn't particularly outlined in the paper. So when we take a look at the lymphocytic, the Dallas criteria, it was able to detect 22 out of the total, I believe it was 47 lymphocytic myocarditis cases that were diagnosed, and then 25 were able to be additionally diagnosed with the use of immunohistochemistry. From an eosinophilic standpoint, the Dallas criteria was able to identify 3 of them, but then 3, they didn't really provide exactly what they used for the diagnostic criteria, but did say that immunohistochemistry was not helpful in this subset because they really used CD3 in order to provide that immunohistochemical diagnosis. And then sarcoidosis and giant cell myocarditis are presumably histochemical light microscopy diagnoses. However, that wasn't specifically delineated either. So what were the outcomes, or what actually happened to these patients? 20 of them had immunosuppression, so that's 20 out of 57. So a relatively low number actually had immunosuppression secondary to this diagnosis. All of the cases of eosinophilic myocarditis, sarcoidosis, or giant cell myocarditis had them, so that's 10 right there. And then the lymphocytic myocarditis, 21% of those had immunosuppression, and of those, 2 were that acute variety, and 8 were in that subacute or chronic category. Interestingly, these were not associated, immunosuppression was not associated with a reduction in adverse outcomes, or at least the adverse outcomes that they analyzed. The p-value was 0.6 on this particular one. So you do wonder if there's some confounding features here, because certainly I would have expected giant cell myocarditis and eosinophilic myocarditis and likely sarcoidosis to have responded pretty well to that. So we can discuss this in a little more detail later on. They did provide this graph, which I thought was extremely helpful, or this chart, which was very helpful. So essentially, they took adverse outcomes predominantly as the patient having to undergo heart transplantation, ventricular assist device placement, or death. And they took each of these in individual categories, and then they did a composite poor outcome that they looked at as an entire group. So if a patient had any of these outcomes, they were lumped into this group. From a standpoint of what this chart is trying to tell us, the dark red here are those cases that were positive by the Dallas criteria, and then the light blue would be negative by the Dallas criteria. The accompanying bar right to the right of those solid lines that has kind of a candy cane stripe on there, these are cases that we ended up being able to diagnose by immunohistochemistry. So you can see the increase in sensitivity that was seen with immunohistochemistry within those patients who had a composite poor outcome or within individual categories. I'd also draw your attention to the fact that there's a kind of a significant outlier here, where in severe ventricular arrhythmia actually had very little with regard to increased sensitivity with immunohistochemistry. Overall, they said the p-value in this composite category was 0.049. I think we could have a healthy debate about whether or not that's significant, but regardless, the point stands that the sensitivity was increased significantly, or it was increased quite a bit by the use of immunohistochemistry in these patients. With regard to viral PCR, this was attempted in 38 patients out of that total of 57 that were positive. There were 8 cases that had viral nucleic acid detected in those individuals. And then with regard to imaging, 33 patients had cardiac MRI of the overall 99 that were screened or included in the study. And I found this point really interesting because it's sort of reverse of what we typically think about imaging. But essentially, 18 of these patients, of these 33, had myocarditis by immunohistochemistry on endomyocardial biopsy, but only 6 of those were diagnosed with myocarditis by imaging. So in this case, endomyocardial biopsy was actually more sensitive than imaging, which is not what we typically think of. We kind of think of the reverse, but an interesting commentary nonetheless. This is a figure really discussing that overall outcome of patients who had inflammation on endomyocardial biopsy and comparing that outcome to their overall clinical parameters. So over here we have hemodynamic parameters, including baseline left ventricular ejection fraction, the end diastolic volume of, I believe it was the left ventricle, and then the New York Heart Association class listed in the graph on the right. I'll first draw your attention to the red and brown or tan line down here. So the red line really shows a patient who has inflammation and had a favorable clinical class or hemodynamic parameter. But the brown line shows that there was inflammation and unfavorable clinical parameters. So really showing that your clinical stage or findings on echocardiography were very predictive of overall outcome. So when I first looked at this, I really thought, okay, so what does it matter if we're seeing inflammation on endomyocardial biopsy? Well, if you delve a little bit further, it turns out that if you match for clinical class or hemodynamic parameters, you actually have a worse outcome if you do have inflammation detected on endomyocardial biopsy than those that have no inflammation but similar unfavorable clinical parameters. I didn't see a sub-analysis on whether this was significant or not, but the trend at least stands across all graphs that are shown here. So with regard to their discussion, they really wanted to drive home 3 points, and I'll talk about 2 of them in a bit more detail. The first one, immunohistochemistry criteria is superior to Dallas criteria for the detection of myocardial inflammation. I think that their conclusion here is relatively valid. We did see increased sensitivity with immunohistochemistry over just histologic diagnosis of myocarditis and inflammation in the heart. That one is harder to argue with. The presence of inflammation by immunohistochemistry correlated with worse prognosis, decreased left ventricular ejection fraction, and ventricular dilatation. And I think this one, they certainly have good data to back it up. They listed two nice figures that essentially show that immunohistochemistry was better at detecting those patients who were going to have an adverse outcome, and that inflammation in the heart showed or portended worse prognosis in these patients who had kind of matched clinical parameters. I think one thing that I am a little the one thing that I still question, or I think really could use additional exploration, is the fact that there was no reduction in these adverse events by immunosuppression. So if we're going to say that inflammation correlated with worse prognosis and with worse hemodynamic parameters, we really need to prove that inciting inflammation, when taken away, also correlates with better prognosis. Now, that could be due to a number of different things in the study. So the sample size was low. Certainly, there were only 20 patients who we had a chance to look at from this standpoint. So this is something that is wonderful fodder for a further study and provides good questions that we can follow up on. The population was mixed. So there was an acute myocarditis, there was the subacute or chronic picture of myocarditis, and certainly those patients may have different outcomes based on immunosuppression as well. And then this was over a 22-year period. So, there could have been mixed treatment strategies over that time as well. And it's very hard to know exactly what protocols were pursued in these individuals outside of saying immunosuppression, yes or no. It's not necessarily always just a categorical variable like that. So this point needs further exploration, but certainly one that's interesting to bring up. And then I editorialized this just a bit when we were talking about imaging already, but essentially the fact that in this study, endomyocardial biopsy was more sensitive than imaging. There's some caveats to this too, as there always is. So the Lake Louise criteria that was used on cardiac MRI was that of 2009. The 2018 version that has come out more recently is thought to be more sensitive and includes T1 and T2 mapping, which are techniques that weren't necessarily available to the Madrid group when they acquired the data for this study. But overall, something that is interesting and also brings up the fact that we need better correlation with imaging, because certainly imaging does provide a global picture of myocardial function and myocardial inflammation and edema, and we need to understand how what we're seeing on histology better correlates with what's coming across on imaging. So with regard to just general thought or points for discussion and fodder, I thought that the study was well done. It provides some important insights to challenging questions. I do think that it would have been really nice to see the outcomes of the acute group versus that subacute or chronic group, or what they term the inflammatory heart disease category, because I think that we may be seeing a bit of a confounder in some of the data and the outcomes based on this mixed picture. And as I mentioned, the treatments probably varied over time, and so we don't have a very clear picture of how all of these diagnoses and treatment would stand up in today's clinical protocols. And then histiocytic inflammation was relatively unexamined in this particular study, which makes sense because it's not really one of the things that we focus on when we're talking about acute myocarditis, but one that maybe we should be focusing on a bit more. So with that, oh, sorry, one more slide. I also think, as I mentioned, we need to understand the relationship between imaging and histologic findings just a bit better. And then really trying to figure out what is our gold standard. So if endomyocardial biopsy is not sensitive enough and maybe imaging is too sensitive, where is that medium, or are we just chasing our tail with regard to really having a good picture of what myocardial inflammation is and what it means? And I would love to have enough cases that we could compare cardiac MRI to autopsy findings and really try to understand that a bit more, because your autopsy isn't as biased with regard to endomyocardial biopsy and sampling issues as we would if we ran this study just based on the biopsy specimens alone correlating with cardiac MRI. With that, I can delve into the second paper, or we can stop and chat a little bit. I'm looking at Dr. Wang to see if he has a preference.
I don't, but I think continue will be pretty good, right? It's
Perfect.
related papers.
This one is a bit shorter, so we'll have a little bit more time for discussion. But this paper, I wanted to explore that histiocytic component, what we've talked about with regard to seeing increased histiocytes in the interstitium of patients with COVID-19 related heart disease. And really, is this a clinical picture or a histologic picture that we should be paying more attention to? So this is a great publication that came out recently in Cardiovascular Pathology about the spectrum of macrophage predominant inflammatory myocardial disease presenting as clinical fulminant heart failure. So these patients came in and they were doing terribly. They underwent endomyocardial biopsy, and then there was this histiocytic inflammation associated with that presentation. So really, how much should we be paying attention to this, and what should our criteria be therein? So the authors start out and say that the histologic classification of myocarditis currently does not really include technically a macrophage predominant or histiocytic subtype. And so they went back to make a case for this and to essentially say, hey, we've seen 6 cases over the last several years of patients who came in fulminant heart failure, and we saw a whole lot of histiocytes in the interstitium, sometimes associated with myocardial injury. And here are the characteristics of them for our data sets and moving forward with evaluating this question. So all of these patients were in cardiogenic shock and underwent endomyocardial biopsy for a diagnosis related to that, and trying to understand what the etiology of their heart failure, acute heart failure, was. Each case underwent a number of different stains. I've listed them here for you, including a C4D, a CD68, a CD3, and then a combined histiocyte and endothelial cell marker. The immunopositivity was quantified both at 200 and 400 times original magnification. I am not going to go through each of these patient histories, but I did include them in case there were questions with regard to it during the discussion point or during the discussion part of our talk today. So essentially, patients 1, 2, and 3 are listed on your screen now, and then patients 4, 5, and 6 and the details of their clinical course and their symptomatology and background medical history are all listed here for our reference in case we need them. Figure 1 shows an image of what they were seeing, what the authors were seeing on light microscopy. So essentially, the take home here is that case 1, or listed in panel A here, had a distinct clinical picture, a distinct histologic picture from the other 5 that were included in the study. And what they saw here were areas of complete histiocytic dropout. A complete myocardial dropout by these histiocytic proliferations or histiocytic areas, nodular areas. The rest of the cases had predominantly interstitial histiocytic inflammation without these areas of myocyte dropout. The biopsy findings are listed here for your review. I'm pretty sure that this should be 4, 5, and 6, the cases as listed here, because the parameters are different within each category. So just as you're going through it. I do want to point out that by CD3 immunohistochemistry, most of the cases had a significant number of T cells associated with this inflammation as well. But the key here is that there was a significant number of histiocytes within the interstitium. And by protocol, this would basically take it out of the realm of an acute lymphocytic myocarditis because there are too many histiocytes present. And I'll go into that in a bit detail in a couple more slides. But these were the number of histiocytes that were quantified per high power field. It's also listed per millimeter squared, which I didn't highlight for you because one of the cases was simply too small to be able to quantify it. And with only 6 data points, I wanted to have as much information as we can here. So the end result or the end description of these 6 cases was that there were essentially 4 cases with myocyte necrosis. 2 didn't have it, and 1 case had that distinct zone of myocyte loss, like we talked about in the histologic images of Figure 1. 5 cases, interestingly, had microvascular narrowing by mononuclear cells. So there was a vascular component to these particular cases, and as such, this reminded the authors quite a bit of the histologic picture that we see in antibody-mediated rejection when we evaluate cardiac allograft specimens. So they wanted to pursue this finding a bit more, and they did a duplex stain, both with histiocytic markers and endothelial markers, as well as a C4D. And they noted that the majority of cases had variable C4D staining. So some of them had them in a perisarcolemic pattern, some of them had it in a capillary based pattern, but there was C4D staining present, indicating perhaps that there is activation of the complement cascade as part of this process. They did follow up electron microscopy in 2 cases, both of which showed mononuclear cells, sorry for that extra S, in the capillary lumens. So here's an image of their C4D immunohistochemical stain, showing that there was variable positivity by this immunohistochemistry in these cases. In the discussion, they really focused on the fact that the SCVP, the AECVP, really recognizes certain subtypes of myocarditis, including lymphocytic, polymorphous, eosinophilic, neutrophilic, and granulomatous. But a pure histiocytic myocarditis really remained poorly understood and perhaps not characterized as much as we could be doing or we could be providing. The WHO and World Health Federation definition of myocarditis excludes cases that have greater than 15 macrophages per millimeter squared. I'm presuming this is because of the issue that this could be associated with like a healing ischemic injury or something of the like. I actually had a hard time finding this reference, but that was listed in the paper, so and it was referenced. So this particular criteria stands with regard to this paper and why, even though there were a lot of lymphocytes in these cases, it wouldn't necessarily qualify as a lymphocytic myocarditis. The authors bring up that they can't necessarily exclude the fact that some of these could be due to a chronic ischemic injury. Only one of these cases really had an angiogram, so it's possible that there could be a vascular or ischemic component to the histiocytic inflammation. And they also brought up the fact that maybe there's a chronic disease component because several of these patients had underlying systemic lupus erythematosus or a chronic systemic disease process that was really uncategorized at the time of their endomyocardial biopsy. And that's delineated just a bit more here with regard to there being variable patient presentation and some sort of systemic disease in 4 out of 6 or 2/3 of these patients, is suggesting that maybe this could be a secondary involvement of a more global systemic process. And again, could there be a confounding ischemic injury problem here? And then is it possible that there's an antibody-mediated pathogenesis? So could there be an antibody-related disease process similar to what we see in antibody-mediated rejection in allografts? Globally, I think this is a very interesting question just because of that increased observations of CD68 positive cells in the myocardium of patients who are dying of COVID-19 related heart disease or with COVID-19. So these 6 cases really provide us with a bit more information and a bit more insight into what we might be seeing in these individuals. I will mention before we move on, and I didn't write it down as a bullet point, but none of these patients had viral PCR, so we actually don't know if this could have been a virally mediated process either. So I talked a lot about this commentary. This is, I think, the last slide right after the first article, but essentially to bring it back to a very high level and talk not just about these papers, but about what we're seeing and what the trends are here. I think we really have a need for several different, or we have a need for more data points with relation to moving forward with this inquiry about myocarditis and how we can best diagnose it. Certainly, we need to understand what that chronic inflammatory component is in all sorts of heart disease, in normal, in dilated cardiomyopathies or other cardiomyopathies. We need to understand what that inflammatory milieu is before we understand what the pathogenic component is. And we need correlation with clinical outcome, because that's really how we'll know what is pathogenic and what isn't in these patients. We need to understand these histiocytic forms of inflammation a bit more, and I think the second article really highlights those questions and provides more fodder for us to explore with regard to that. And then lastly, as I mentioned, I think that imaging is going to provide us with a lot of information and a way to synergize or perhaps give us a bit more sensitivity than what we can do by endomyocardial biopsy. But where is that interplay, and how can we really take that and understand it better in order to provide a better diagnosis for these patients, and then perhaps, hopefully in the future, better clinical outcomes. So with that, I want to thank you for your attention, and I also want to say that I know there are a lot of people on this call who have an exceptional amount of knowledge in this area. I don't pretend to know all of it, or even 10% of it. So I'd really like to be able to draw everyone in, get your thoughts on these articles, get your thoughts on the directions that we're going, and hear your expert commentary as well.
Thank you. Thank you, Melanie. These are two really highly inflammatory papers. Now let's open for the discussion.
I have a question. I don't know if I can be heard.
Yes, we can hear you, Dr. Cole.
I was kind of underwhelmed by article number 2. They had 6 cases. They had a heterogeneous group of patients. I think it's great for discussion, and they may have some valid points, but they didn't do any controls for their cases. They had several images of interstitial fibrosis. I think you got to have a control for that, because I do autopsies on all kinds of people, and I see some degree of interstitial fibrosis commonly. And one of the patients, the morbidly obese guy, I think it was number 4 or 5, he had hypertension. He also had psoriasis, which was not discussed in the paper as an autoimmune disease. So I wasn't particularly impressed with some of the images. Now, I don't have the degree of expertise that many of our members have in myocarditis, but when they showed, I think it was one of the first images, figures that had several photomicrographs, most of them had no myocyte destruction. One did have, the first one, which had that nodule of lymphocytes, and I understand, macrophages, and that had one probable necrotic myocyte, but that was it. There was another one they showed, which looked like the so-called necrotic myocyte was intravascular. The other thing is, if they're saying this is like AMR, well, they don't have a case for that, because maybe one of their images with C4D might have fit the criteria. I would say one, but then they had serum staining, which is nothing. They had, I think, a cluster of cells. I don't know exactly what, maybe they were myocytes, but they were just diffusely stained. And you got to have, even I know, you have to have endothelial staining of C4D to call it AMR. So I think it's good for discussion, and I applaud the fact that we reviewed it. That's not the issue, but I would conclude, and I'll shut up now, but I would conclude that there needs to be a lot more work, and this is only a very early beginning, and it's not compelling, in my opinion, to make a case that the myocarditis may have some elements of AMR.
Thank you, Dr. Cole. I agree that I think it really provides us with an outline and a structure for moving forward on some of the questions that it raises. And I think it's very good for that reason to allow us to see insight into maybe a few focused cases of here's what we're seeing with myocardial or macrophage inflammation, and here are the clinical outcomes. But I think it does raise a lot of really excellent questions, many of which you outlined in that analysis. So thank you for your thoughts on that.
Sure.
This is Dr. Fallon. If I could pile on here with Stephen's comments, I totally agree. C4D is a great marker of ischemic necrosis of myocytes, and that's mostly what we're seeing in those pictures. And that first picture with the macrophages filling up a space is obvious healing ischemic necrosis. There's actually, if you look closely, you can see hemosiderin-laden macrophages in that field. So Max, you should have sent this one to me to be reviewed by Richard.
As the editor of the journal who accepted this paper, I will defend my decision because number one, there is this issue of in the COVID spectrum of COVID heart disease of a macrophage predominant inflammatory process.
That's all ischemic necrosis.
In your opinion, but in other people's,
I think it's not just my opinion. I think we've all landed it in that area.
Well, I haven't landed there yet, but more fuel for fodder is a paper that we have accepted and is in press that you can get to on the journal's website. Another paper talking about the relationship of describing a significant number of cases with macrophagic increase in the interstitium and dealing with the question of its association or lack thereof with necrosis. So I recommend that you all take a look at that paper as well. And the reason we accepted the Goldman paper was to be inflammatory and to put forward the concept, is there some type of macrophagic inflammatory process that occurs in conditions other than COVID? And I agree that this is 6 cases, but it needs much more study or confirmation. And if it can be proven to all be ischemic, so be it.
So I'll jump in here and say that I agree with Jay and Steve, and fall firmly in the camp of what we're seeing with these macrophage predominant infiltrates is ischemic injury. I think we need to be really careful about also cause and effect. So when we see inflammatory cells, are they actually causing the damage, or are they're secondarily recruited as a consequence of the damage that has occurred due to some other etiology? I would also, there are a couple other issues that are raised. So, I mean, I think it's an interesting, the second paper was an interesting paper to be inflammatory. I think we potentially could very much muddy the waters. And I really think we need to be very careful about creating a new category of histiocytic myocarditis. I don't think that such an entity exists. Those macrophages are being called in for another reason, but that's—
How do you know that? How do you know that?
So what are the mechanisms for specific macrophage recruitment? I mean, they're not responding to MHC. They're responding to cytokines being elaborated by other cell types, responding to the expression of adhesion molecules being made by endothelial cells, but something else is driving their recruitment and their activation. They are not responding primarily to a myocyte.
But how can you have your cake and eat it too if it's ischemic injury of the myocyte and it's not responding to the myocyte?
Well, no, but I mean, but in fact, then that necrosis through all the mechanisms that are in various textbooks are driving an inflammatory milieu, such as tumor necrosis factor
Mhm.
and interferon gamma, other things like that, sentinel cells, because of the ischemic necrosis, inflammasome activation, et cetera, that is driving the secondary recruitment and activation of
Is
the,
it,
if the histocytic population.
is it not an alternative hypothesis, at least to be pursued, that in the COVID cases, we're dealing with this so-called multi-inflammatory syndrome, and that the macrophages in the myocardium are part of a systemic inflammatory process?
MISC and MISA are not associated with myocarditis per se.
That's right. But that's the whole point. This is something not lymphocytic myocarditis, but is it a manifestation of the heart participating in this multi-inflammatory state of COVID?
I think it's a secondary, not causal, but a secondary recruitment of inflammatory cells. They may contribute to further damage, not arguing that.
Okay, you're saying that what I just said might be true, but we don't want to call it a new class of myocarditis. I can accept that.
Okay. The second point in the first paper, where they're using CD3 and accepting that as a pure marker for T cells, is also inaccurate. Depending on stimulation, the various cytokine environments, tumor necrosis factor in particular may drive macrophages in subsets to express CD3. So it is also not a pure marker of a lymphocytic myocarditis to look at that. And I'm also really curious. I mean, when I look at a biopsy or even look at an intact heart, I don't think that I'm missing a lot of inflammatory cells that suddenly become magically enriched and enhanced by doing immunohistochemistry. So just where are those hiding that we miss them on regular H&E?
I agree, and I wanted to bring up the point that I find the World Federation criteria very confusing or not well defined. And the critical issue is, if you look at some of those papers, they seem to imply, at least some of them, that you need to have not only the 15 lymphocytes per meter squared, but associated myocyte necrosis. But I think the way these criteria are being applied, they're being applied to finding a few lymphocytes without evidence of necrosis. And to me, that's nothing more than the borderline Dallas criteria.
Mark?
In other words, if you look at Melanie's paper, she had a footnote in her presentation when she showed the IHC 50% versus 25% for Dallas. She had in parentheses no necrosis.
Mm-hmm.
So
yeah, I worry that the IHC is an overcall, and Melanie raised that point. I think it's valid.
So I like to add, and I really appreciate the discussion and Melanie's great presentation of these papers, that it's provocative to think about do the number of inflammatory cells, if you look at them by IHC, which I do think is a better way of viewing them by H&E, does it have outcome? Does it drive something? Is it telling us something about the heart failure, or myocarditis by counting these? Because we get CD3 and CD68 on all of our native heart biopsies, and it's variable. Some of these cases have very few inflammatory cells, and some, particularly the ones post-COVID, and you call it MIS-C, have numerous macrophages around the vasculature. And whether we're calling any of this myocarditis or not, that one paper suggests that it has outcome effects. And I think that's something we all should be cognizant of. And I'll add, there's a second Japanese paper that shows the same thing. In dilated cardiomyopathy, and I'll put it in the chat, they show the more inflammatory cells, the worse outcome as well. So I think this is all very provocative for all of us.
I agree, Mark. I think it's interesting to have that. But what I'd like to see is if we're able to modify that factor. So in that first paper, the immunosuppression was not correlated with adverse or with an improvement in adverse outcome. So if that is actually what's driving it, if we remove that, why aren't we seeing an improvement? And it could be sampling or it could be some other thing in that particular paper, but I think it's worth studying because in the end, whether or not we call it myocarditis, we really need to bring it back to clinical outcome and understand how what we're seeing under the microscope correlates with that and how we can treat these patients in the best way possible.
Well, the whole idea of if you make the diagnosis that's the indication for immunosuppressive therapy, the immunosuppressive therapy for ordinary myocarditis has a very mixed, checkered history. And what I think our guys do is that they are relying much more now on mechanical circulatory support, ECMO, et cetera, but they still get the biopsy basically because it makes them feel better. If we can say there's myocarditis demonstrated histologically, and they may throw in a little steroids too. But I think they're basing their therapy primarily on hemodynamic support more than the immunosuppressive therapy.
Another interesting point to me is that, say, we look at the clinical picture. Another way is the etiological picture. So for that, they do PCR in 38 patients, right? And positivity is only 14%.
Right.
So I just don't know if that number sounds right.
Well, if you look at the papers from our friends down the street here in Houston, the Texas Children's Lab, and then the Berlin group, they report these very high numbers of positive PCR. But I finally got a PCR panel going for 13 viruses here, and I am totally underwhelmed. And I'll just tell you, in our series of acute heart failure biopsy for suspected myocarditis, our incidence of positive biopsies using basically the Dallas criteria is 40%. And the PCR is very low. We only recovered parvo B19 virus in a few cases, and parvo B19, as you all know, is just floating around everywhere. So I think by the time they get to our hospital, it's an autoimmune disease.
Mm-hmm.
Yeah. So.
Well, I for one would just like to thank Melanie for her presentation today. It was awesome. Keep up the good work, and thank you for bringing these papers to our attention.
Well, thank you, Dr. Fallon. Thank you all for your very valuable feedback and thoughts.
What a great discussion.
Yeah, I think we have a lot more to explore and a lot more to understand when it comes to myocarditis and how we make the diagnosis and what it really means for our patients. So I thank you all for being here. I thank you all for the excellent discussion, and I think this is an area where there's more to come or to be continued.
Yeah, it sounds like it would make for a good point counterpoint type presentation at one of our meetings.
Very good.
Sure.
Thank you. Thank you, Melanie. It's a very good presentation. Thank you.
Thank you all. Good to see you.
Good job.
Thank you.
Bye.
Nice.